Okay, hello everyone. Happy Monday. I'm really excited to be here with Austin for another ALA session and really looking forward to it. We have an all internal affair, as Robbie likes to say. Lorenzo's going to be presenting the case, Magnus is going to be scribing, and Sana is going to be doing the teaching points. Yeah, I'd love to pass it to Lorenzo, see how things are going.
Hello, everyone. I glad to be back here with another case. Hopefully you will enjoy it as well. I think it's a very unique one. Not very common here in Portugal. That's why I brought it for you guys. Maybe it's more common there in the States. Let's see how it goes.
I am very scared, but Lawrence always brings amazing cases. Yeah, any updates from Magnus or Sana at all?
No, not really any updates, but looking forward to Lorenzo's case.
Okay. Thanks everyone. Looks like we have the whiteboard. Yeah, Lorenzo, whenever you're ready, and Austin, you want to take the first aliquot?
Okay, so we'll start with the first aliquot. I have the case divided in about five aliquots in total, with the last one revealing the diagnosis. So in the first aliquot, we have a 69-year-old male that was found collapsed on the ground near a restaurant. He was alone and the event was unwitnessed. On initial assessment, the patient was obtunded and unable to provide a clinical history. He opened his eyes to vigorous verbal stimuli, moved all four limbs in response to pain, had intact pupillary light reflexes, and produced speech, although it was disorganized and bizarre. And I'll stop there.
Okay, very nice. Thanks so much. And definitely a not an uncommon situation that you might encounter in at least in the United States, where you find a patient that is by themselves in a sort of vulnerable position and you don't really know how they got there. It seems fortunately for this person, they have some amount of cognitive capacity to be able to sort of move all of their extremities, be able to produce speech. But as Robbie has sort of taught us, like we haven't heard that he can walk, we haven't heard that he can eat. So like sort of the basic functions that we would really rely upon. Only one of the three of them is sort of intact. So there's going to be a lot of work to do to really understand what the problem is. And I think the most challenging situation here is that the pretest probability that this person will have abnormal labs is extremely high. So then you have to wonder to yourself, what is a consequence of the patient just being in the vulnerable position that they were in and for how long we were there versus what is signal to why the patient ended up in this place in the first place. So I think the only way to sort of inform you about that is to, unless there's like a very clear derangement, but I think that sometimes that can be really difficult to tease out. But I think it's the past medical history or of the patient or trying to obtain any sort of collateral that you could would help you sort of glean any sort of insight into what's happening. So if you are able to see that the patients come to your hospital system before and you discover that they have like substance use disorder or they have a history of certain medical conditions like diabetes and are on insulin that could predispose them to have an event such as this, then I think that can certainly be helpful. But I think the main challenge here is to not only understand like what exactly happened, but also the consequences of this person's body and then teasing them out. But it'll be difficult to sort of really make a whole lot more progress, at least for me, until we sort of better understand the syndrome. But Alec, what are you thinking?
No, excellent. A unique start to the case, and like you said, something that we see not uncommonly, at least where I practice at a safety net hospital here in the United States. And so I think sort of the fact that it was unwitnessed really makes it difficult to define two really important things when we're trying to solve clinical problems is the time course, right? And then also really trying to figure out how are you going to describe this syndrome, right? Right now, we can keep it very broad and say that the patient has encephalopathy, but it's really hard to be more specific than that, right? I don't know, is the patient just having like hallucinations, right? Are they just disorganized? Do they have dysarthria? And I think it's really difficult to make more progress there. And I think most people are going to frame this as like a hyperacute to acute problem. But how do we know that there isn't more of like a subacute tail to this if we lack the history? So I think in these situations, like as an internist, oftentimes we don't get the first touch with the patient. I don't work in the ER like Robbie does, but talking to EMS can be so helpful. Like a lot of times for patients that are recurrently admitted to the hospital, since they work in a similar area, stay in a similar area, do they have familiarity with this patient? Um, what did they see when they arrived? Were there people around him that sort of describe what was happening? Or, just to be able to get collateral from friends or family that perhaps had been there before would be super helpful. Or like what was on their person when they arrived? So I think all those things are super relevant. And then also, like you Austin said, trying to get a sense of the background if you can, by looking in the electronic medical record, which in the United States, unfortunately, not all of our systems communicate, but a lot of them do. And sometimes those can be helpful clues as well. But I think it's right now, it's really hard to be determine what the problem is and the time course of the problem. And I think that's what makes sometimes these cases very challenging. So yeah, I think as we'll move forward, hopefully we get some more clarity from there and can better define what these problems truly are. So yeah, I'll pass it back to Lorenzo.
So, in terms of past medical history, the patient has known hypertension, dyslipidemia, obesity, is a former smoker but with an unknown pachyuria history, and is also a former alcoholic. He's been abstinent for the past 5 years. In terms of family history, it's non-relevant. In terms of social history, he lives in Lisbon in a rented room with daily social support for meals and medication administration. In terms of medication, he takes bisoprolol, amitriptyline, losartan, sertraline, trazodone, and oxazepam. And I'll stop there.
Okay, thanks so much. So I don't know if it's just my screen, but I can't see the whiteboard for whatever reason. Or okay, it was just my screen. But so we've learned a little bit more about this patient. So it has a history of hypertension, obesity, tobacco use disorder, and some prior alcohol use disorder that seems to be in remission. Um, and then it seems like the patient lives in a rented room and gets sort of assistance with medications and with meals. And I guess I would be curious, is this just perhaps like social infrastructure that's available in Portugal that we don't have here in the United States? Or is there some cognitive reason or that the patient is receiving this? Do they have some underlying intellectual impairment or disability from a prior stroke or, something else that would require this? So I'd love to learn a little bit more there. And I don't think I caught all the medications, but noted quite a few centrally acting medications. So amitriptyline, sertraline, I believe a benzodiazepine, and also trazodone. So those already, when it comes to encephalopathy, are one of the first things you think about substances in particular, something that is either prescribed or something that the patient takes otherwise that's not prescribed, or the withdrawal of said substance. So those are certainly things that I would be tracking and trying to get a sense of, is there excess of one of these, or perhaps is there an absence of one of these, and how that could be contributing to the patient's presentation. And certainly the vital signs and physical exam can be helpful in differentiating that. Then I would also love to know if the patient has why he's on a lot of these medications that are typically used for psychiatric disease, and just wondering if the patient has a background psychiatric disease history, and whether or not it's possible that the patient maybe ingested more of these meds than initially intended or purposefully so. So just I think clarifying with the caretaker that's involved with him, do they keep all of his medicines and administer them? Does the patient sort of take them themselves and they just sort of help as needed? And also the patient says that he's been abstinent from alcohol and smoking, and of course I want to trust that, but also want to clarify with anybody there that does something change? Did the patient have a relapse? This is a chronic disease that people deal with, and it's not uncommon that people have slip up, and that's not to be negative, but just something that we need to understand to better help the patient. So I think that's the way I'm reflecting on the past medical history. Hypertension and hyperlipidemia are so common. Certainly you would have to think about the risk of vascular events and things like that. But right now, I think we don't have a great sense of the problem, so I'm less inclined to put a lot of stock into that at this moment until we get a little bit more clarity. But also, I'd love to know what you're thinking of all this.
No, really, you touched on everything. Yeah, my main reflection was there's a disconnect between what we've heard from the patient's mass medical history and the medications that they take, as well as like the amount of support they're receiving. So I agree, it'll be really good to get some clarification on that. And then, as you said, I think the vital signs in the exam will be telling. So let's get the next aliquot. Thanks, Lorenzo.
So the patient was rushed to the ED, and on admission, his vitals were BP of 135 over 80, a heart rate of 78, a respiratory rate of 26, an SpO2 of 85% on room air, improving to about 97% with 3 liters binasal cannula. His temperature was 36.5 degrees Celsius, and his fingertip glucose was 180. On general exam, he looked hydrated and was tachypnic, using accessory muscles, and had generalized retractions. On cardiovascular, pulmonary, and abdominal exam, all were within normal limits. On neuro exam, he had poorly intelligible speech. His pupils were isochoric and photoreactive. He had spontaneous movements of all 4 limbs with no muscle weakness and no pathological reflexes, specifically negative Trommer, Hoffman, and Babinski signs. Gait was untested. We also did an ABG while on 3 liters by nasal cannula, and he had a pH of 6.77, a PCO2 of 18, a PO2 of 114, a bicarbonate of 2.6, a base excess of -32, a lactate that was high with no value reported, a sodium of 141, a potassium of 5.3, chloride 111, calcium 1.22, glucose 179, and an hemoglobin of 14.6. Due to showing signs of respiratory exhaustion, the patient was intubated and an arterial line and urinary catheter were placed with a urine output of 1.3 liters. He was started on IV fluids with sodium bicarbonate for correction of the severe acidemia. I'll also give you the initial labs. He had an hemoglobin of 14.3, a white blood count of 22,000 with neutrophil predominance of around 90%. He had a platelets of 171,000, a BUN of 59, a creatinine of 113, a normal liver panel, an LDH of 561. His ions were similar to the ABG. He had a phosphorus of 7.2, a magnesium of 2.5, a CRP of 7.3 within normal limits, a troponin of 28.1, marginally elevated, a CK of 665, and a myoglobin of 871. And I'll stop there.
Okay, wow, a rich amount of data and I think really expertly presented. So thanks so much. I think Alec, what I'll try to do is um, I'll focus on the exam and then you can try to, I'll give you some time to sort of like go through the labs and then we can like go back and forth from there if you're okay with that. So based off the exam, at least vitally, you'll see, hey, like he was going through, Lorenzo was going through each one. And it's like, okay, blood pressure not too bad, heart rate not too bad, temperature's not bad. And then it's like, uh-oh, the respiratory rate's 26. The patient's now is hypoxemic, requiring oxygen corrected relatively well, with just 3 liters. But then we generally looked at him, and he appears very unwell. He has increased work of breathing, your accessory muscles. So already we're very, very worried, and that was then like dramatically corroborated with the ABG. So Alec will talk a bit more about that. But interestingly, we didn't. Sometimes when people are breathing very quickly or not able to take in big deep breaths, then it's difficult to get a good sense of the pulmonary exam, and then it can be debated about the value of the stethoscope in the scenario, anyways. But for another time. But we didn't hear anything. So is that an approach to say, hey, maybe this person has uh, has a exam negative, or maybe potentially like we haven't gotten the imaging yet, but exam negative dyspnea and hypoxemia, and that has a differential diagnosis. But I think to begin with, I wouldn't put too much stock in that as a data point. But all we can say is that hey, this person is very sick. It seems to be primarily from a respiratory standpoint. And then the only other like prominent exam finding I would say is the obviously the speech. It seems like what was found in the field by the EMS was sort of then corroborated. Like he just has very poor, like incorrigible speech. we're not getting the sense of a sort of toxidrome based off of the pupils. We didn't hear about the skins being particularly dry or wet or anything to get that sense, which I think is what Lorenzo is trying to guide us towards. So, what do I make of that? I'd say in a person with some amount of comorbidities, definite renal dysfunction, a lot of centrally acting medications. It's hard to know if the speech issue is something that I need to invest a lot of time into or not. And that makes it, I think, authentically in real life, I probably wouldn't invest too much in it on first pass. But I have to ask myself, if everything else is okay, like he's able to follow commands, which I don't have a great sense of that, then, is this truly localizing to the speech centers? Like I need to look at his brain to say that he has some sort of like aphasia process going on. Or is this just a consequence of, as Alec talked about before, maybe he's had some sort of prior cerebrovascular event, and within the setting of being severely acidemic, is having sort of like a recrudescence of symptoms, and then on top of that, having sort of a toxic metabolic effect. I think that's a tough call for sure. I think it's analogous to the scenario where you have a patient that's altered, and it's like, should I get the LP? Should I not get the LP? So I think realistically speaking, from a management standpoint, this person is too sick to even think about getting like brain imaging right now necessarily. So you'd be trying to address the respiratory status first, and then you'd have some time to answer that question. But those are kind of my main takeaways from the exam. So hopefully that was enough time that I bought you, Alec, to review the labs, and then we can go from there.
No, never enough time. But no, Austin, I really love what you shared and sort of the tension with the how to find this speech. Um, I guess it seems like the power throughout was normal. But I guess I would love to know, like, was that just, they kind of put the hands on the patient and the patient was sort of moving the arms and you could get a sense that the strength was grossly intact, or was the patient like actually able to follow commands and this is truly an isolated deficit? With the profoundness of the tachypnea and like the insane acidosis that the patient has, I'm more inclined to think that this is just a consequence, and less associated with focality. But it is something, like you said, we'll need to track. And right now, the thing that's going to kill the patient first is what is causing this profound acidosis. So I think I would be really primarily focusing on addressing that, and then sort of seeing what changes. And now that the patient is intubated, that's going to become even harder to assess. So probably at some point, would you stabilize the patient? Since there was potentially some focality and the patient came in altered, more likely than not, they're going to get some sort of head imaging, probably a CT non-con to start. But then you could decide how much further to take that from there. So when we look at the labs, patient has a very significant neutrophilic leukocytosis, which, if I had a pH of 6.7, I would hope my white count was 22, just from like how profoundly ill you are. But I think because of the presentation, we definitely need to think about the possibility of infection, and notably the fasting, or I don't know if it's fasting or not, but the glucose is a little bit on the higher end. I imagine the cortisol response in this patient is astounding. So a little bit of a high sugar is not unexpected. But just wondering if the patient could have underlying diabetes and how that may play into the presentation in the setting of a very significant acidosis. We don't have the chloride. And so it's hard for me to, assess what the anion gap is. I'm going to go out on a limb.
I wrote the chloride down as 111.
111. Okay.
Uh,
So 111 plus 2, so it's 113, right? So the gap is what, 28 at least. So massively elevated. So I think the question will be now is what is driving this anion gap, and basically like want the lactate, want the ketones, and then we're going to have to think about other drivers there. I'd love to know if we have the patient's baseline creatinine to know how far off this is. I assume that the conversion of like 113, I think it was just 1.3, and I see that that's written there. So it is elevated, but not terribly so. But I'm not sure where exactly in time this is. The CRP being normal, it's a little bit peculiar, but frankly, I'm just going to be ignoring it because I don't know if it's really going to change what I'm going to do in this patient. The LDH is quite high, but again, I don't know if that's sort of cause or consequence. The hemoglobin is normal. That doesn't mean that the trend isn't normal. And I'm, at least in my lab, like around 230 is the upper limit of normal for LDH. I don't know if in Lorenzo's lab it's a little bit different, but with the setting of the CK and everything else, I sort of would just be tracking that as well. And it looks like Lorenzo said about 220. So, yeah, I mean, the CK is high, not really that high to explain the creatinine elevation at this point, but I don't know. And as well, this patient was found like, how long was he there? How long was he down? Is his CK going to go up? Is it going to go down? Uh, how we're going to really track that is very difficult to say. So, what I really want to solve now is why this patient has a profound metabolic acidosis, and sort of ketones and lactate are things going to be looking at as well. And certainly there are other things to consider further down the line of other drivers, but I think that's what I would be thinking about it in first pass. Probably as well, looking at the medications, I don't really think of those specifically causing a profound lactic acidosis. I guess I would be calling the facility he lives at, be sure he's not taking metformin or anything else that might be able to drive some of this, and sort of getting further collateral history. But yeah, Austin, I think I'd just be waiting for the lactate and ketones, and probably a serum osm as well, to see if he has an osmolar gap, and then sort of building what to do from there. And yeah, I mean, with a pH that low, and then, I'm sort of wondering, is like the bicarb drip going to be enough? Does this patient need dialysis? Like, how are we going to focus on that? But yeah, I would love to know your reflections as well while I collect my thoughts a little bit more.
No, yeah, I think that's excellent. I think, to your point, like what objectively do we need to solve right now? And I think it's like the person has respiratory failure and they have profound acidemia that's metabolic in origin, right? So like those are the things that we have to solve. The respiratory status, we're going to make some progress with imaging for sure. I think it's reasonable to empirically treat the person for infection, of course. Though it seems like, as you said, it would not be inconceivable to expect that they could have a leukocytosis that's neutrophilic predominant from just a severe illness that they're experiencing. But then, yeah, as you said, there's a anion gap acidosis. I think the utility of a bicarb drip in this particular circumstance is like relatively nuanced, I would say. So I know some intensivists that would do it. I know some intensivists that would not do it. I know some nephrologists that would do it. I know some nephrologists that wouldn't do it. So it's it's an interesting like management pearl, and maybe Lorenzo can teach us about that later. But I think, yeah, as you said, I would just sort of go through the most common endogenous causes of a gap, which would be sort of urea, which we know is high, but not high enough to sort of explain this presentation, I would say, just from my gut feeling. Lactate, which we know is high. We weren't able to sort of quantify it more than that, but we know that that's a driving component here. And then the ketones, as you mentioned, so we'll be checking a beta hydroxybutyrate. I think, thinking through what causes those things, lactate, like this person could be, significantly hypoperfused, though there's some evidence like, this is just a snapshot in time, and maybe this is a signal to the fact that the patient wasn't down for that long. I guess it'd be nice to know, like, when's the last time you saw this person? When you talk to the people that sort of help to take care of him. Or it could be like, his creatinine will be 5 next and he has 0 urine output, though he did have, more than, I think, a liter of urine when they put a Foley in. So it just sort of, I guess I'm sort of trying to get clues from the time course a little bit, or the severity of the event that happened, to see if there's a disconnect between, or like the delta of like, oh, the lactate and the pH is this, but the person, as far as end organ dysfunction, like the creatinine's not terrible. The the troponin is like basically nothing. Like there seems to be, do you know what I'm saying? Like there's markers of end organ damage, and some of them are like not very exciting. And this one, the only one that is sort of like the acidemia or maybe the lung issue. So like, I guess I'm sort of struck by that disconnect, and whether or not that's going to manifest in the form of some sort of like toxin mediated ingestion or something like that, or it's just time will tell if we're going to see the rest of the sequela on this patient's body. Like that's sort of something I'm hoping to understand. I don't think I articulated that particularly well, but maybe you can chime in, Alec, and just give any other thoughts before we pass it back to Lorenzo.
No, I totally agree. I think sort of clarifying the meds with the facility, and metformin, SGLT2 inhibitor, like other things to think about. And then I think it's this patient as well, where like we don't know the time course, like getting a sense of when was the last person time that somebody that knows this person saw them and like were they normal? What is their baseline? What is not their baseline? Maybe they have this sort of speech impediment at baseline. Like I'm not certain. What had changed in their life recently. And I think as well in this situation with the degree of lactic acidosis, which we haven't defined, but I presume it was like undetectably high. um, and we don't get a sense of like profound systemic hypoperfusion in this moment. We don't know what like preceded this, but thinking about sort of type B lactic acidosis, and probably it's mixed here. But this is a patient that should just get empiric high dose thiamine as well, because of the encephalopathy and the lactate as well. So yeah, I think those are. I don't really have much to add here, but like we got to figure out this acidosis and treat it appropriately, and then hopefully the other things from there will sort of fall into place. So I'll pass it back to Lorenzo to get some more info.
So, in terms of more history, we did contact the social workers, and they told us that he was last seen well in the morning that he presented to the ED. He has a slight cognitive impairment, but no abnormal speech at baseline. In terms of his day-to-day life, nothing changed. He was attending his appointments due to his alcohol disorder, and everything was going well. He had been taking his meds as appropriately as he was instructed to, and there were no new meds introduced. In terms of his evolution while on admission, the pH, the lactate, and the bicarb levels were getting better with fluids, but only marginally, so the patient was started on dialysis. He was eventually extubated, and on neuro reevaluation, the patient was alert oriented ×3 with no focality. His pH went from 6.7 to 7 and then to 7.1, and then that was when dialysis was started. And then the pH resolved, and the bicarb followed the same trend, going from 2.6 to 10 and then to 24. After these changes in the ABG resolved, the patient was suspended, the dialysis was suspended. However, after that, the creatinine started to trend upward, going from 1.13 to 3, and then 5.7, and then 9.2. The patient became anuric, leading to reinitiation of dialysis. At this time, we did the tox screen that was negative for benzodiazepines and alcohol. He had a UA that only showed 40 RBCs. We did a viral panel for HIV, Hep B, and Hep C, which were all negative. We did a head CT scan that showed chronic vascular lesions with no evidence of acute vascular lesions or mass effect, with no ventricular or bone abnormalities. And we also did a full body CT scan with angio, which showed obstruction of the right lower bronchus, possibly due to secretions, with associated atelectasis, and also showed focal thickening of the gallbladder fundus, raising suspicion for a malignant process, with no signs of ischemia or vascular occlusion of any organ. With this CT in mind, and assuming that he could have right lower lobe pneumonia, he was started on ceftriaxone and azithromycin. And I'll stop there.
Wow, it's an amazing case presentation, Lorenzo, and what a case this is. So I guess I would love to know briefly before I talk is, so it sounds like how many days was it into his admission that dialysis was stopped and then the creatinine trended up to 9?
So, if I remember correctly, he started dialysis on the day he was admitted. He did 2 days of dialysis. It was stopped, and then after 1 day, it was restarted.
Okay. No, thank you so much. Really, really helpful. So, it seems like the patient's clinical syndrome rapidly improved as we corrected his acidosis. But as soon as the dialysis was stopped, his renal function profoundly worsened. And I assume his acidosis also got worse again as well. And the question is, what are we missing? So this patient was here for 3 days. If he took anything, since he seems like he was peeing and he was getting dialysis, most of the toxins, unless they're sort of like lipid based, really should be out of his system at this point. So I worry that we're missing something that's ongoing with the patient that was driving his initial clinical syndrome that we were only sort of band-aiding over, with the dialysis, which is really quite peculiar. And so, a lot of times when people get worse in the hospital, it's usually things that we do to the patient. So medications is one to think about. I'd also love to know if the patient had any like major hemodynamic changes, like they had for very significantly hypotensive to have ATN or something like that, or if they were on pressors at any point of time.
Not that
Um,
I'm aware.
okay. But I would also, think about as well as this creatinine has gone up, what other investigation have we done to into that? And so the UA showing 40 RBCs, not normal. I'd love to know what the baseline is for the patient. Was this attributed to traumatic Foley placement, or um, you know was there initially on the UA a lot of like blood but very few RBCs? But it sounds like 40 is pretty decent. Um, I guess I have a little bit of bias, but one thing I've seen in the past is somebody came in with like some rhabdo. It got initially better with fluids and then continued to get worse. And it's because the person's leg was ischemic. And then the patient developed, had fallen and then, got compartment syndrome in the leg and just kept getting a CK that kept going up and up and up for a few days and until eventually did a better exam and somebody found it. So I guess I would be going back to the patient and doing a good thorough physical exam. And now that they're a little bit more oriented, trying to get a history of what happened. Did they take something? Were they feeling sick? Is there a little bit more sort of acute, subacute tail to this, or is this was actually all hyperacute? Because we lack a lot of clarity on what's driving the syndrome. So I think I would just go back to like what problem I need to solve. And it seems right now we have a very significant acute kidney injury, and we'll just be trying to think of the buckets there. So if they didn't take out the Foley, as long as it's functioning well, we want to be sure that that's not obstructed. But if it isn't, that makes post-renal less likely. Seems like they haven't been profoundly hypovolemic. The LDH being that high, definitely could think of ischemia. Could also be thinking about hemolysis or other sort of other breakdowns. So I'd love to think about the hemoglobin trend. Um, the other thing with the LDH would just be thinking about leukemia or lymphoma. So I guess would be assessing the white blood cell count. Did that get better? Has the differential changed? Did the smears show anything? The uric acid, like we can check it here with the creatinine 9, is going to be high. So it's going to be a little bit harder to interpret there as far as like TLS or something. And a pan scan of the CT, just reading it now, shows a little bit of lymphadenopathy in the liver hilum. It looks like an infiltration of the omentum. Okay, I didn't see that. So yeah, initially with like a little bit of obstruction in the right lower bronchus, like assuredly this patient, like while intubated, had probably had some secretions and other things. So I was putting a little bit less stock in that, maybe just some atelectasis or a mild pneumonia, but not enough to explain the clinical syndrome. The gallbladder fundus wall being thick, I think in my experience, I see so many patients that are critically ill. If they have any bit of venous congestion, like the gallbladder just kind of looks thick and it's often more noise than signal. But we don't really have a lot of other signal in the patient. It seems like the abdominal exam is benign. The liver chemistry tests are fine, at least initially. I don't know if those have evolved. And if this was some sort of malignancy, the question would be, why would this come up hyperacutely? So that's a little bit peculiar. Did the patient get acalculous cholecystitis or something else? And that was just sort of driving the clinical syndrome. But I'm not sure why that would continue to get better. And then this lymphadenopathy in the liver hilum, is that just reactive? How big is the lymph node? This infiltration in the omentum, are they worried about like mets into the omentum or something else? So I think I'm just a little bit confused about why. And yeah, so a lot of rambling, but in short, basically the patient has an AKI that's getting worse in the hospital after stopping dialysis. And the question is, we basically need to act like they're newly admitted and figure out why that is. And then I think from there can layer in how this gallbladder thickening and hilar lymphadenopathy is explaining the clinical syndrome, understanding that if this is cancer, like why all of a sudden this would happen. I think, going back and reassessing the labs that he initially came in with, like the CBC, the BMP, and everything else, and the LDH and all that, and acidosis would be helpful for me to kind of make further progress. But Austin, please add some clarity to my delirium.
You're okay. Yeah. And yeah, to clarify, Alec has been awake for 36 hours, so we appreciate him discussing today. So I just had a couple of questions for Lorenzo. So number one, do you happen to know, was he making urine while he was on dialysis initially, or no?
Yes.
He was. Okay. And then the second question was, what type of dialysis did he get?
Continuous technique.
Continuous technique.
Continuous
Okay.
re Yeah.
Perfect. Okay. The reason I ask those questions is, so number one is when you are on dialysis, you're taking over the job of the kidney. So oftentimes having a decrease in your urine output is not uncommon. But if you are retaining some amount of residual renal function, then that's a signal, as Alec was alluding to, that maybe there's something that had acutely changed or that had progressed during this period of time. The second is in this type of scenario when you've thought about the possibility of a ingestion or toxin, then the way that you go about treating that from a dialysis standpoint is actually different. Most of the time, if you are worried about something that you need to clear, then you actually need to do hemodialysis, not continuous renal replacement therapy, in order to meaningfully remove the toxin. So this becomes nuanced, and so I rely on our nephrologist a lot. But typically speaking, if you're particularly worried about a toxic ingestion, then usually you're actually going to try to do hemodialysis instead of continue renal replacement therapy. But nonetheless, I think this is a wonderful case to demonstrate the power of like as the beginning, as we talked about at the beginning, like what is signal to the disease? What is consequence to what happened to this patient's body? And what is incidental on all of the evaluations that we did? So here's my feeling so far. Um, the gallbladder, totally incidental. I could be totally wrong about that, but I'm going to say that that's probably incidental here. The second is the CT of the lung, like probably consequence of the event that happened, as Alec alluded to before. And I would imagine unless the patient became like volume overloaded, like probably the oxygen status, like his hypoxemia improved like over time as his mentation improved, his respiratory status improved, etc. And then the uh the urine, as Alec was alluding to, I don't know if the RBCs are again just sort of like a consequence to the Foley placement, etc. Like it'll be good to have sort of a trend. We didn't hear about any pyuria or proteinuria at all. So I think if you're trying to localize that, as Alec alluded to before, it seems like it's unlikely for us to have a hemodynamic or pre-renal AKI. It seems like we're unlikely to have a post-renal cause since we have placed a Foley, it was functioning appropriately. The person had been making urine and now they're not making urine. So it seemed to be in the intrinsic bucket. And again, the trend of the UA will be helpful. But if you say, hey, like how can I make progress of seeing hematuria with an intrinsic renal impairment, like where I can localize the disease. And I think, one way to do it is like in the tubules. And I think this is where the other tricky thing is. It's like if the patient ingested something or something happened to them and like their kidneys were fine, but we just needed a few more days to get it to be worse. And then over time, like we were basically just potentially masking a decline in renal function because of doing the dialysis initially. And if we hadn't done dialysis, maybe we would have seen that the patient's creatinine would have been 1.13, 1.5, 1.7, and 3, then whatever. Like maybe we're just masking them, or maybe there's something else that happened. But I guess I'm inclined to believe that based off of the presentation, this trend or trajectory was going to happen, but we were just masked by the initial dialysis that the patient received. So now I think how do you make progress in this case? And I think this is my personal feeling is like, hey, we were in the RX aspect of this, like the treatment aspect, like the person has encephalopathic, severely acidemic, requiring urgent intubation for respiratory distress. Like, fortunately now, like they're better from a respiratory standpoint. They're fully oriented. They can provide a history. So now finally we're in the diagnostic arc to this. And I think the first thing you have to do is go back to the patient and talk to them and be like, hey, what's the last thing you remember? And what the heck happened? And what was going on? And I think that will be very powerful more than anything that you can order here. Like, of course, we're going to need to do the appropriate evaluation for the CT findings that are suggestive of malignancy. But I think this all comes back to going back to the patient, talking to them, obtaining a history, and seeing if we can garner any progress. I would do that first before trying to invest really heavily in the labs or trending them. The only thing I will say that Alec, alluded to was the idea that, could there be hemolysis? Could the person have rhabdo? But I think the other one with everything together is like, could the person have tumor lysis syndrome? I don't, it's very uncommon to have solid malignancy cause tumor lysis, as we've reflected on in this space before. It's possible, but you could see like elevated LDH, renal dysfunction, like, you could check the uric acid, as Alec was alluding to before, and like try to make progress on all these things. But it seems a little bit far-fetched to me. So really what I want now that we're out of the acute treatment mode is like, let's go back to the patient, talk with them, and then we can frame everything that we see in the labs from there, and then base off the trend that has been happening during this period of time. So excited to learn more from you, Lorenzo.
So, answering to some of your questions and other ones in the chat, we don't have osmolar gap in our hospital. Unfortunately, all of our osmolarities are calculated, not measured. We don't have the instruments to do it, so we can really do a gap. The lactate, we could only measure it after it was getting better. It was trending downwards, so it was stupidly high. And essentially, when we went to talk to the patient said that his daily life was going as it used to. There was nothing that he noticed that changed, essentially. We did in order to better understand the renal distress, the severe AKI. We repeated some labs and we did some studies more directed to better understand the etiology. And we essentially had normal levels of total protein, albumin, a normal SPEP, normal levels of immunoglobulins, and a serum free light chain ratio, normal levels of C3, C4, and ANCA. After 4 to 5 days with his urine cath clamped, we were finally able to collect some urine and we sent it to our lab to see it under the microscope, because initially we only had the urine dipstick. And I'll show you what we saw. Can you see my screen? Essentially, this is what we saw. This is a picture taken with my phone, and this is a snapshot of what we saw in the computer. Essentially, the official read said that we had hemoglobin +3, a moderate amount of hyaline casts, isomorphic RBCs, calcium oxalate monohydrate crystals with needle or cigar-shaped morphology, suggestive of ethylene glycol intoxication. Due to the findings on the CT scan, we also pursued the gallbladder and we did a CT-guided biopsy that showed a moderately differentiated adenocarcinoma. And so the final diagnosis, it's an ethylene glycol intoxication with severe lactic acidosis and a gallbladder adenocarcinoma with local regional metastasis.
Okay, wow, yeah, thanks so much, Lorenzo. And I was just very happy that you didn't ask me to interpret the urine microscopy because I was like, I think those are crystals, but like really incredible case. And I think, in the end, I think there's sort of two tragedies in this situation. The first is that the patient was struggling so much that they used this substance, and like even when they were critically ill in the hospital, intubated, everything, like they still didn't feel comfortable sharing that this event had happened. And then secondly, like by chance, like the patient came here and presented, and we discovered that they had, pretty advanced adenocarcinoma already, which probably portends a pretty poor prognosis in this patient. So a really, really powerful case. Like, unless I'm missing something, you know, uh, I think it was a really great demonstration of like the hecticness that can happen and really the power, even in 2026, the power of like going to talk to the patient. And even then, like understanding that the patient might not disclose information to you or share with you things in order to make progress. Like that's what makes really our jobs really, really hard. But also like tells you why a computer can never replace us because a computer will be like, oh yes, this is this. It cannot be ethylene glycol because they did not, ingest ethylene glycol. So like there's of course many nuances to that, but I think it was a really tremendous case. And then I think going back to the reflection from before, like the disconnect of like the profound lactic acidosis and the rest of the clinical syndrome, and thinking like there's probably something exogenous that's happening here that ended up bearing fruit. And Alex sort of alluded to it with the metformin, but the idea that there's like a other toxic ingestion was fair game as well. So, and then I think in the end, and Lorenzo can chime in, but I think the renal dysfunction was just as we thought. Like he was gonna get it eventually. It just took time for it to show up, and then going up on dialysis initially, like did the job that it needed to do, but then sort of masked the fact that the patient was going to develop renal dysfunction anyways. And then I hope that the patient maybe had some renal recovery in the end, but we'll see what Lorenzo says. But Alec, what were your reflections?
No, just an amazing case, and I share in those reflections. Um, and I think, you know, the way that ethylene glycol can cause this too is you initially get a clue. It's more of an osm gap, and then as it gets metabolized, it becomes more and more of an anion gap, and you can get very significant lactic acidosis. But I think the time course here, as once we were able to get that he was fine in the morning. So this is something that he took, right? This has to be almost an ingestion because we didn't get any clear hemodynamic fingerprint to cause such a profound lactic acidosis. His gut wasn't dying, right? He wasn't in florid septic shock. There was really no clear focality. Um, so a toxin, was probably of primary importance. And then Austin, just an amazing sort of catch and just sort of teaching about the CRT and how that is not the preferred modality to clear toxins. And maybe like if the patient had been on hemodialysis for 3 days, maybe that would have been helped, right? Maybe some of this could have been helped. Whereas if he was on CRT for a couple of days, right? The clearance of that toxin just isn't there. And that's why after stopping it, after those additional days, he probably continued to get worse. Um, and then, I think too, if you do have an osmolar gap available in your hospital for patients for cases like this, it could be really helpful because if you had noticed the osm gap was really high, you should have given this patient fomepizole, right? And that could prevented a lot of this from happening as well. Um, and I think I'm not sure. I'm sure somebody mentioned it in the chat, but at least in the United States, if you would have found that, just a quick call it a poison control, and they will guide you through this as well. Um, some people say like people have like a particular odor or whatever when they do it or they drink it or whatever. And I think too, just all the more important to try to get the collateral. Like, did they see a bottle of something standing next to him when he was wherever he was at? Was he outside of like a auto store and like had a bottle there? So context is everything. And then Austin said like, just the power of the history, like every day going back and speaking to the patient and trying to understand like what has been going on in his life to do this. Understanding that alcohol use disorder is a lifelong disease, and I'm sure he's been fighting it in his own way. But yeah, just an amazing case, and very unfortunate you found the gallbladder adenocarcinoma. But as Austin stated, like just because you find something, you always have to think about in the clinical context is to actually explain the clinical syndrome, and this was just purely coincidental. Um, so yeah, I'd love to pass it to Lorenzo to get his reflections, and then we can head it over to Sana for the teaching points.
Yeah, I just wanted to add as well, Robbie had put in the chat, which I didn't pick up on real time, but there's this concept of a lactate gap. So basically in the arterial blood gas, you can see a lactate show up really, really high. But if you check the lactate in the sort of traditionally from blood work and from the venous side, the lactate might not be as elevated. So if there's quite a stark difference between the two, that can actually be a clue to the possibility of ethylene glycol poisoning. So maybe that was the idea that's like off the chart so high, like couldn't be even be measured. But from going through the chat just now, I don't look at the chat in real time because I try to stay authentic. But looking at it now, I think it's could be a clue to what was happening as well. So yeah, Lorenzo would love to hear your reflections on everything. Thanks so much for presenting the case.
Thank you very much for the beautiful discussion. This was a really cool conundrum that I faced on mid last year, maybe June. We received the patient on our ward after he went through ICU care. And after he arrived on our infirmary, he was already in terms of, well, he was still dependent on dialysis, but in terms of acid-base alterations, they were all corrected. Granted, he was on dialysis, so they would surely be like that. But what we tried to approach basically was the lactic acidosis. That felt like it was the main driver of all of the clinical picture of the patient, whether it would be the encephalopathy, maybe could explain the kidney failure. So in terms of lactic acidosis, we started to think like type A, type B.
Type A, we didn't have any fingerprint to show us that he had localized or systemic hyperperfusion, whether it be the CTA that didn't show any ischemia or stress from the organs, internal organs, or blood pressure dip before or even in the ICU. So I think type A was out of the question. Then what we had was type B, and type B usually we have either toxins and some other miscellaneous causes like the Warburg effect from some types of cancers, usually lymphoma, but that usually doesn't lead to a very high lactate. And then I think the main clue that I found that led me to the diagnosis was the fact that the kidney didn't really, there was a big disconnect with the fact that he was on dialysis. So he was on dialysis and then he got worse in terms of kidney function while on dialysis. And that to me felt like there was something that was inside the kidney or was getting cleared out with the dialysis and then precipitating in the kidney. And then I think the urine sediment was key for the diagnosis. We eventually biopsied the kidney just to get a better understanding of the prognosis, because even with 2 weeks of dialysis, his kidney function wasn't getting better. And since the ABG changes were already normalized, we talked with our colleagues from the toxicology department, and they said that either administering alcohol or fomepizole at this point was futile. So we were just waiting around to see if the kidney function started to get better. And once we did the biopsy, I don't have the picture, but essentially the kidney was replete with stone crystals inside the tubules. So we were doing urine sediments every week, and he was still letting out a lot of crystals for about a month. Fortunately, he regained renal function and is now off dialysis.
Yeah, wonderful. Thanks so much for the teaching and your care and just your detective work. And I'm glad to hear that, at least from a renal function standpoint, the patient had a positive outcome. And, sometimes it can take, and you have better knowledge of this than me, but sometimes it can make many, many weeks, even months, before people sort of will decide if they're going to have enough renal function recovery. And even Alec, I remember as a resident, he admitted a patient from a nursing home who was on dialysis. And every day he's like, this person's making 500 cc's of urine plus a day. Like, do they really need dialysis? And then the patient came into the hospital on dialysis and then left the hospital without dialysis. And I think even like eventually left a nursing facility. So like, it can take a lot of time and for the kidneys to recover. And so, I'm glad to hear in this case it worked out for them. But okay, well, thanks so much. We'll pass it the teaching. We'll pass things to Sana so she can deliver the teaching points.
Thank you so much, Lorenzo, for the awesome case and absolutely brilliant discussion, Dr. Austin and Alec. So initially, we had a patient that presented with loss of consciousness, which was unwitnessed. So for us to figure out the cause, important clues can be the past medical history, and if it was witnessed, we can also get some associated symptoms and the time course of presentation. From the history and the usage of medications and assistance, we were thinking that the patient might have some cognitive impairment. And then with the examination, we learned that when patients have dyspnea, the respiratory exam may be falsely negative. As for the poor speech, we thought if it is a baseline deficit or a resurgence of symptoms from past CVA due to the acidemia. And the labs, we first realized that the patient has a lot of acidosis, so we need to stabilize the patient first. And the blood glucose could be from underlying conditions or the cortisol response from this. Then we also saw that for high anion gap metabolic acidosis, we need to check the classic mud piles agents that could be causing these. The patient then was placed on dialysis, which showed, and even on dialysis, the renal function tests were getting worse. And after getting removed from dialysis, the patient's condition worsened even further. And since they were making urine while on dialysis, it pointed to a more acute etiology. So probably an intrinsic cause that was masked by the dialysis rather than an iatrogenic cause. When we came to the imaging, we saw that the gallbladder was thickened, which and the read of that was likely pointing to malignancy, but malignancy causing such a acute presentation was unlikely. Then on urine analysis, we saw that there were crystals that were characteristic for ethylene glycol. And the teaching points we had from this was ethylene glycol can present with initial osmolar gap followed by an anion gap. It can also have a lactate gap, that is, ABG might have very high elevated lactate compared to the VBG. And the treatment is fomepizole, which is more effective if given early.
Very good. Thank you so much. Great initial teaching points, and hope to hear many more from you in the future. Well, thanks so much, everyone. I apologize for my terrible sounding voice, but I'm sure we'll get some great comments on that on YouTube later, and I'm glad to receive them. But have a good day, everyone. Stay safe. All right.